Hello, I'm Dr. Dan Cox, a professor of counseling psychology at the University of British Columbia, and welcome to Psychotherapy and Applied Psychology, where we explore practical insights with leading experts. Today, I'm thrilled to welcome back Dr. Craig Bryan, a world authority on suicide prevention. In our conversation, we discuss reframing suicide prevention goals, creating a life worth living, reconceptualizing risk assessment, legal considerations in suicide prevention, and much more. And please feel free to leave a comment below. And if you enjoy this conversation, it'd be much appreciated if you hit the like button and subscribe to the channel. This episode starts with Dr. Bryan talking about reframing how we think about suicide prevention. Let's jump in.
Yeah, and I think what you're getting at there is I think sort of a philosophy of suicide prevention that I think has emerged within myself over many years, which is to reframe the idea of suicide prevention not as preventing someone from dying or kind of conversely maintaining or keeping someone alive, but instead helping them to live a good life that's worth living. Um, and and so in the initial stages of working with someone who is suicidal, especially someone who really doesn't feel like they have a lot of meaning and purpose in life, I do have to kind of take a little bit more of that approach of I need you to stay alive long enough for us to figure this out. And so would you be willing to kind of join me in this process and perhaps forestall the decision for a while. Um, you can always kill yourself later, which is usually a pretty provocative statement for suicidal patients to hear from a clinician. But part of this process will be right now keeping you alive because it's going to be really hard to find purpose and meaning if you're not around to actually experience it. And I found that by shifting that philosophy and communicating that to the patient and explaining that the reason why I want to have this conversation and perhaps have you go through this uncomfortable experience of not having access to highly lethal methods serves the underlying goal and purpose of reducing your personal suffering and finding purpose and meaning in your life, which I have found to be the primary goal that many suicidal people have when they initiate care.
A couple of the things that stood out when I was reading your writing about this was one, it was a foregrounding of sort of a client-focused approach, right? And then sort of, I'm going to, I don't know if I fully mean this, but a backgrounding of suicide prevention. That doesn't mean to ignore it, but that means that like suicide prevention in service of client-focused care, patient-focused care, rather than, I'm putting 100% of my attention on suicide prevention, that and only that. And that is a means to that's the end. That's it. If I get there, I win. That's what we're going for. It's like, no, we need to do that in service of patient-focused care.
Yeah, and I think I think what helped kind of push me to think about the issue in this way was really it's listening to the lived experience of suicide attempt survivors, of others who have struggled with suicidal thoughts, who have said, um, don't just keep me alive because my life to me seems unbearable. I'm hurting, and so when you are primarily motivated and you're like telling me that I need to stay alive, what I'm hearing, the message received is I need to suffer forever, and that's from my perspective as someone is like that's awful. Like what? That's not a very attractive option you're offering me here, and so that was something that I've definitely come to appreciate over time of saying, okay, let's kind of move away from thinking of suicide prevention as merely keeping people alive, because I think that does also motivate us to use coercive strategies, and to instead say, let's create a life that's worth living, because then we render suicide obsolete. Because if you felt like life was good and you were happy and you had purpose, then probably, can't say for sure, but there's a good probability that you wouldn't be experiencing this misery that's driving you towards suicide. And of course, most of our patients are kind of like, yeah, that's exactly right. And so then it's like, okay, so let's talk about how the first step in this process is keeping you alive and long enough for us to get to that point, because probably not going to be able to solve all the problems today. It's probably not going to be this week or next week either. And so, kind of, where are we at? Are we going to work together on this? And I think that collaboration is just absolutely key. So it's kind of like flipping that question, like I said before. It's not why do people die? It's why do people choose to live? And by shifting the focus of the question and the idea of suicide prevention away from death towards staying, like living a good life, I think that's just really powerful.
One of the other feelings I had reading your work was on this topic was slow down, like as a clinician, like slow down. I think that oftentimes when we're working with people who are, acutely suicidal, I don't know. I think it's a pretty universal experience of like, oh my God, I got to figure this out quickly. I got to reduce the suicide quickly. And I sort of, as I was reading about means restriction counseling, a big piece of it is like, well, if I'm going to join with the client and the client is going to feel that, and that we're like, that takes time, right? Like that is not that's not me talking a lot. That's not me reading off of a form or filling out. Like that is that takes time. So that was one of the other things that I really took away from that was like, slow down.
Yeah, yeah, slow down. That anxiety that we feel as clinicians, it's natural. We're afraid, and we're afraid because there's death kind of looming, right? That is the thing that we're afraid of. Um, and so that fear and that anxiety motivates us to behave in certain ways that lend themselves to, checklist-based approach, coercive interventions, things like that, which we're recognizing now are not particularly effective, and in some cases may actually be working against our purposes. And so if we kind of go back to the point that I made at the beginning, which is conceptualizing suicide as from a decision-making framework of choice, I emphasize to clinicians like your patient can kill themselves, and there's not a whole lot you can do about that.
Mm-hmm.
And you could do everything right. You could provide really good care. You could be really compassionate, really warm, really understanding, and sometimes suicide wins anyway because no treatment is perfect. Some treatments are definitely better than others, but even those better treatments are not 100% effective. And so what we need to do is kind of disabuse ourselves of the responsibility of I'm responsible for the decision that my patient makes and recognize that our responsibility as a clinician is to provide effective treatment and to give our patients those skills, those strategies, those opportunities for them to hopefully then make a different decision than suicide. And I think being able to separate that responsibility of what really is it fundamentally that I have control over as a clinician, that it's like, well, I have control over delivering really good care and being compassionate. Um, and so that I think helps to reduce the anxiety for a lot of clinicians because that is something that I think we can do. And we could actually do it really, really well.
So this leads really well into the next thing I want to talk about, which was collaborative risk assessment. So everybody's familiar with risk assessment. What do we mean when we say collaborative risk assessment?
Yeah. Yeah. So I would say this kind of harkens back to the kind of the idea or the theme of these sort of checklist based approaches. And again, this is very common now, I think, in many clinical settings, healthcare agencies, of having these forms that we fill out that delineate certain risk factors for suicide, and then we're supposed to fill it out, and then we stratify risk and all that kind of stuff. Um, and I think that can lend itself to a very impersonal clinical encounter, because here the task is I have to fill out my form in order to meet compliance requirements. And so I'm going to oftentimes just ask the questions to get the information that I need to follow the rules. So sort of to not get in trouble is often another way of framing it. Um, and so that I think directly contradicts the importance of building these collaborative relationships with patients. And so a big approach now in the collaborative assessment approach is to, in essence, say, you can put the forms aside, put the documentation stuff there. We'll fill out our paperwork later, and just sit with the patient and ask them what's going on. Like, how did you arrive at suicide? And what are the things that contribute to it? And what we find is that through this collaborative or narrative approach, we actually tend to get all the information we've got to fill in on our form anyway, but now there's a coherence to it. And this is the interesting feedback we hear from clinicians when we train them in these collaborative approaches, where they say, yeah, up until now, I've been collecting information. And so I have my yeses and nos, and I check the boxes and I write things down that the patient says, but there isn't like a coherent
Sure.
integration of ideas. And that lends itself to this question that I'm asked all the time. It's sort of a frequently asked question in suicide prevention. What are the most important variables? What should I weight most heavily in my risk assessments and in my questions? And there are none. The answer is there are none. And so what we have to do then is accept that, collect the information, but do it in a way that we can start to see how this particular decision emerged in this particular context at that particular time for this particular individual. And because then that makes it actually really easy for us to start thinking about, oh, I know what we need to do to make a change. In this person's life, and how to guide them perhaps to a new trajectory. And so the good news is that when we take that approach, of course, patients really like it. They rate us as more empathetic. They're more likely to engage in treatment. They utilize the strategies. They do their homework assignments. They take their meds. All those types of things because they feel heard and they feel listened to. And it also, through this approach, helps them to actually make sense out of their own experience. That sense of why do I feel this way and why am I doing the things that I'm doing? The collaborative approach allows them to piece it together, and they say, "Oh, now it makes sense to me," and it also makes sense to me why you are, recommending that I do certain things in certain ways.
So why even do risk assessment?
Yeah,
Not why collect a narrative story of a person's experience. That's not what I'm asking. I think that is
sure.
clear. The why do risk assessment?
I think so. So I do a lot of legal consulting in the United States, for malpractice cases, and here again, I think it's a uniquely U.S. cultural thing of like suing each other. Um, and I think one of the consequences or the outcomes of that sort of legal kind of cultural context is this notion of stratifying risk of you need to collect all this information and you need to piece it together and then kind of have a sense that sort of like there's an implication you should have known that this was going to happen, right? And I think that leads to this notion of risk assessment. Um, and so it's very, very common, not only in the United States, this happens everywhere, but to kind of think of this as like, is this person low risk, medium risk, high risk, or something like that? And I think we often utilize that risk assessment framework couched from the lens of this almost like this prediction game of
Mm-hmm.
what is the probability, my assessment of the probability that this person is going to engage in a particular behavior. And that's where it's like low probability, moderate, high probability, something like that, or imminent probability, something like that. I've since found it helpful to kind of like, okay, we can't predict the future. Suicide in particular cannot be predicted. And so risk assessment then I think could be more usefully reconceptualized as more of like a needs assessment. And so when I'm working with a patient and collecting the information from them and documenting in my notes, with low, medium, high risk, things like that, in my head, what I found it useful to do is think of that as what are what's the level of service needs for this individual. And so in particular, someone who's high risk, what that signals to me is this person needs suicide focused treatment. So they need DBT or BCBT, they need crisis response planning, things that go directly at suicide risk. Whereas someone who is low risk for suicide, perhaps something like maybe let's just treat their diagnosis because right now the suicide risk is not at the forefront of the clinical picture for this individual. So maybe we can be thinking of other psychotherapeutic medication based modalities that hit on their problems in life or their mental illness, things like that. And so along those same lines, I work with clinicians to reframe this question that's often asked of, well, when do I hospitalize? And I'm like, well, I don't know. Like, there's not really a clear answer for that, but what I have found helpful to think about is in my risk assessments, thinking of what does the patient need? And if in my assessment, the patient needs sort of like 24/7 care, they need medication stabilization, they need something about their mental status to be stabilized, maybe it's psychosis, mania, acute intoxication, something like that. So they need medical monitoring. Then that's where I'm starting to think of something like inpatient care. Whereas they might be high risk because they're really suicidal, but in my assessment, they need help managing distress, solving problems. And perhaps those issues are not going to be adequately addressed in a psychiatric inpatient setting. And so that's where I might be thinking of intensive outpatient or just kind of regular outpatient. And so the risk assessment framework, then, like I said, I've found it useful to think of it as more of a treatment and services needs type of assessment.
So everything you said there makes so much sense to me that right we are going to. It makes sense to have some sort of systematic or quasi-systematic way of assessing where this patient is at, what they need, and then using that to inform treatment. I mean, even sort of hope, even if it's not using some sort of a structured form. I mean, that's kind of what any decent therapist
Yeah.
would do, right? With anything. Like, it doesn't matter what it is, that, it's not just, oh, you have major depressive disorder, so this is what we're going to do exactly, right? There's nuance. You collect that. So that makes a ton of sense to me. I guess it's more of maybe I'm just too literal, but I feel like as a field, if when we call it risk assessment for folks who don't have a lot of, they get trained in their graduate training programs, then sort of go into practice. So they don't have they can't spend, hundreds of hours doing research and reading and that sort of thing, that by calling it risk assessment, that it implies that we're doing this to assess risk. And we're not an insurance agency, so why would you assess risk unless it's to attempt to, well, I guess it's still true for insurance agency, right? An attempt to predict and then to be able to do something with that prediction. Like, to me, by calling it risk assessment, why else would I assess risk if it wasn't to assess risk for the aim of prediction and then doing something with that prediction?
Yeah, and I think one of sort of the consequences of thinking about risk assessment in that way is that we often, again, everyone's trying to find like the algorithm. Well, what are the right pieces that go together, which then say, oh, I should hospitalize this
Yes.
person now, or I should do something else. And when I consult with clinicians around this, um, they'll say, well, they said that they had a suicide plan or something like that, and so I think I should hospitalize them. And then, my question and response is, and what will hospitalization do
Yeah.
for this patient?
That's great.
And they
Yeah.
say, well, they're high risk. And I was like, okay, so what is hospitalization going to do for them? Like, well, I mean, it'll reduce their risk. I was like, well, why will it reduce the risk? And usually what most people are is, well, after a few days, the episode will resolve, right? It's like, okay, so time will pass and that will resolve the risk. So can time pass without hospitalization? And what are the things that are actually needed to perhaps move this person out of this heightened vulnerability state? And once clinicians start thinking of it that way, say, well, they need perhaps they're not coping with their emotions very well. They need like self-regulation skills. They have these, they're really hopeless and they need some help to kind of teach them how to view the world in a different way. And it's like, okay, so can you do that without hospitalization? And of course, the answer is yes. And so it's like, so just because someone's got a certain score, a certain number on a tool or a screening method, or they have a certain experience that we've classified as high risk, doesn't necessarily mean that they need hospitalization, because if someone has a plan to kill themselves, that plan isn't like going to vaporize while they're in the hospital. Uh, and that plan will probably still be in place once they're discharged, and then they're going to come back to you. And so, what do you want to be different when that patient comes back to you? And if that intensity of treatment is not sort of directly hitting mechanisms or processes that will fundamentally shift where that patient is, then that's where I'm saying, well, then what's the purpose of hospitalization? And so, but that, and again, that's separate from saying, that they're in a really, really vulnerable state. And so we can start thinking now of things like, well, do we do like phone contact with our patients in between outpatient? Is there increasing the frequency of outpatient therapy sessions? Maybe that's indicated. Have we done lethal means counseling with them? Because if they do not have convenient access to highly lethal methods for suicide, then perhaps the safety assessment of this individual can be adjusted accordingly. Whereas if they have a bunch of really dangerous meds or they have guns in their house, then yeah, maybe I am going to think about this in a very different way, and perhaps hospitalization functions now in a different manner than I'm initially thinking of, simply because again, I've decided that they're high risk.
And I'm curious if this is your understanding. My reading of the literature is that when we look overall, that hospitalization, there's not good evidence that hospitalization prevents suicide. That people obviously die by suicide while they're hospitalized, and then there's sort of a spike immediately after people discharge. Is that
Mm-hmm.
your understanding of it too?
Yeah, that is true. I mean, there's actually never been a study published showing that inpatient psychiatric treatment reduces suicide risk.
Wow.
Um, as you alluded to, there's a lot of evidence showing that in the time immediately following discharge is actually a period of heightened risk. Now, we don't know if that's because, like, is the hospitalization increasing the risk for some
Right.
people? I
Right.
think for some, it probably is for some. But I think the other possibility is that, people are admitted, time passes, their distress will resolve, and then they're release. They return to life. And then in many cases, a lot of the drivers in their life that were sort of pushing their suicide risk have not actually changed
Right.
while they were in the hospital. And so they re-enter the same context that was
Right.
kind of causing the suicidality in the first place. And so a new episode emerges. But there might be now overlaid on top of that, perhaps there are medical expenses. Maybe you've had time off of work and there were other consequences associated with it. So yeah, so there is this sort of, I think, long-standing assumption that this is sort of the gold standard of the highest level of care, but it's actually never been shown to reduce suicide risk.
So with your work sort of on the legal side of things, and I know that, you're not a lawyer, we're not giving legal advice here, but I think a lot of times clinicians do operate, and they're trained this way. This is not a critique of clinicians. If anything, this is a critique of training programs, that they're trained that like we have to hospitalize. I have to do a formal risk assessment. I have to chart it, and I have to, if they meet a certain, if in certain conditions, I have to hospitalize, and I have to do these things, or else I am going to be liable for, right?
Mm-hmm.
So one of my question for you, and sort of based on what you're saying, I guess my question is, if a clinic, and again, not legal advice, but in your experience, when a clinician has a suicidal client and they clearly document the sort of the experience of the client, the needs of the client, blah, 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 and that they clearly document that they are working on serving those needs for that particular client. Like, is that the type of um, what you would, what I'm trying to get at is how can we help therapists to feel comfortable to attend,
Mhm.
to be client focused rather than, litigation focused, and while
Yeah,
simultaneously protecting themselves. That makes sense.
sure. Yeah, no, it does. Yeah, and so there's some advice that I was given very early in my career by David Rudd, who did a lot of malpractice legal work as well. And the advice he gave me was don't spend a lot of time worrying about or trying to avoid trying not to get sued. Because people can sue you for anything. Like you don't even have to do anything wrong. They can just be angry with you and they can sue you for
Right.
something. And so if you invest time and make decisions based on trying to avoid that, that's sort of a fool's errand in many respects. So what you should instead focus your time and attention on is providing good care, because you can do everything right and someone could sue you anyway. Um, and you can be sued and also you can still be a psychologist or a clinician. And so protecting your license, doing good work is actually what matters. And incidentally, if you focus on doing really good work, it actually reduces the probability of you being
Mhm.
sued, even though it can't completely eliminate it. And I found that really helpful, and I try to pass that advice along to clinicians wherever possible. It's something very core to like our team because our clinic it's a suicide care clinic, and so we take very high risk patients. And it's interesting when we're working with new referral sources, they're usually skeptical. They're like, "Are you sure you want us to refer these patients to you? Because these are
Really?
the patients that." Yeah, they're like nobody else wants these patients. They're scary, they're dangerous, they attempt suicide a lot, they have chronic pain, they're complex, things like that. And we're like, no, that's exactly who we want. And so a part of what we've had to do with our team to manage this is to say, no, let's not do defensive medicine, let's do good care. And so we strive for best practices. And so the best defense is always doing things that are evidence based, that are empirically supported, that are rational, that are reasonable. Because it's for us, and would argue this might be true for the field as a whole. It's not a matter of if a patient dies by suicide; it's a matter of when. And
Mm.
so when that patient dies and their family members get together and they think about whether or not they want to file a claim against us, what we want is for their family members and the survivors and any lawyers that they consult with to say, this was really good care that was provided and tragedy struck nonetheless. And so all that is to say is that sort of defensive mindset, it's totally natural and it's completely understandable. Um, Unfortunately, I think it often gets in the way of doing the things that, in my experience doing malpractice consulting, the things that will protect you the most, which is good care.
And so, and to put a little bit more of a, so would it be reasonable to say good care and documenting that good care?
Yeah, absolutely. So I am one of the points I make. So I do actually just did a training yesterday on this topic on like standard of care and best practices. And one of the points that I make is I think we've taken these two terms, standard of care and best practice, and we use them interchangeably, but they
Yeah,
actually are very
totally.
different things. Standard of care, that is a legal concept, but we use it in our clinical practice as a way of sort of synonymous with like good practice or good clinical care. But that's actually what best practice is. Best practice, the definition is doing things and procedures that have been shown through research to actually get you the intended effect. And so the what that means is that best practice sort of refers to it kind of implies what is effective, whereas standard of care basically means what is minimally acceptable within the profession. And there's no requirement from a standard of care perspective to utilize the most effective, most or the most scientifically supported procedures. All that's required for standard of care is that you're doing things that a typical mental health clinician would do in a typical setting. And so it's kind of just what is minimally acceptable within the profession, even if it's not particularly effective. And so we get these two things mixed up, and we're trying to protect ourselves from the litigation based on, in essence, a concept that really refers to doing the bare minimum. If instead we focus on always doing what we know and has been shown to be most effective, by default, you are going to not only meet the standard of care, you're going to vastly exceed it.
Hmm. So have you gotten any, I ask everybody this, what pushback have you gotten for your work?
Yeah, I mean, it's been mixed. I would say some of the work that I've done has been very well received, especially the critiques of suicide prevention, sort of proper, kind of the field as a whole, and a lot of the assumptions. So there are a lot of people, and they typically are people outside of the suicide prevention field, so their family members, friends, patients, people with lived experience who have received it very positively and have said things like, finally, someone's saying it out loud. Um, and then within the suicide prevention community, it's been a mix. I would say most people haven't really said anything, but but I would say that the positive feedback has overall, I wouldn't say it isn't there, but people disagree. I mean, that's what it comes down to, is that, a lot of what I've been talking about really does challenge norms. It challenges our bedrock assumptions, and, and that's uncomfortable. And and so it makes total sense to me that the field as a whole perhaps has been less receptive and open to the ideas. My hope is that over time, at least if someone is raising the issue and rattling the cage, perhaps it'll motivate the field as a whole to maybe improve. Because I personally believe that we're stuck right now and we just keep doing the same thing over and over again. And we're really, really insistent on certain ideas and strategies that, are not really working. I mean, we can't say that they're not working. I say we can't say that they're making things worse, but we really can't say that they're making things better. It's sort of this, lack of evidence or the absence of evidence is not the same as evidence of absence. But but at any rate, it's been interesting, I guess, to say the least, because some people are not happy with they're like, oh crud, here comes Craig again. He's talking
Wait,
about all
so
this stuff.
what's, I mean, I think I have a general sense, but what are like what is it specifically? I mean, you probably can't go through, but that's getting sort of a bee in people's bonnet.
I would say there are a couple areas. There's some ideas that actually have not been resisted very well. So like arguing that suicide is not solely caused by mental illness. That
Mm-hmm.
I think by and large people are saying, yeah, that's actually probably right. And there's still some holdouts who insist is 100% about depression and anxiety. But I would say by and large the field, that's been an idea that's been well received. Um, I would say the one idea that definitely I've not had as much agreement with is it involves like suicidal ideation screening, and I've been a critic of universal screening, not
Mm.
screening writ large, but a very particular approach to suicidal ideation screening, and it's basically screening everybody within a population, particularly in low acuity settings, so like schools, primary care clinics,
I think I
community.
read a paper of yours recently where you were talking about how basically if you do a standard assessment for depression and then a suicide ideation screening, that depression actually is more predictive of than
Yeah,
the SI screen. Is that right? Am I remembering that correctly?
yeah, you are. It's so that's I think a great example, and I feel like as the where people disagree with me, I don't think they fully understand how I arrived at this position because 6 or 7 years ago, I was all on the whole we should screen people all the time bandwagon. If you read my old papers and some of my old book chapters, I'd be like we should be screening more often. And so what changed? Well, I received a grant to basically validate the clinical utility of universal suicidal ideation
Hmm.
screening in primary care. And my motivation, I mean, the whole rationale behind going after, proposing the study and going after these funds was because there are like some bodies in the United States, is the U.S. Preventive Services Task Force, who is, just kind of held the line saying there's not enough evidence to recommend for or against universal screening.
Hmm.
And a lot of people in the suicide prevention field are really upset about that. And I was as well. I was like, that's ridiculous. We should, of
Right.
course, be screening. So I proposed a study, and I said, well, I'll come up with the evidence. If there's not enough evidence, let's generate the evidence. And so I received grant funding to do this. Spent multiple years. Work on the project, and then I analyzed the data when everything was done, and I discovered that I was wrong. That universal screening actually was not very effective. And then, of course, that led me to look at, arguably 50 years of research that have come to the same conclusion, but I was able to see and understand those results in a very different way. So I was able to overcome my confirmation bias. And and so when I tried to start publishing those results, that was really where pushback came. And and the paper that you specifically referenced, we compared the PHQ-9, which is a depression checklist screening tool, and we compared that to kind of explicit asking directly about suicidal ideation, which again advocates within the field have said they've been kind of I think knocking the PHQ-9, saying it's not good enough, it's depression, that's not suicidal ideation. We should stop doing depression screening. We have to ask about suicidal ideation as well. And what we found was that actually the PHQ-9, the depression screening, actually identified a lot more of the patients who eventually attempted suicide than the suicidal ideation items. And so it was the opposite of what we expected. Um, and again, kind of looking then at the full body of research in many respects, I was like, gosh, we actually have known this for a long time, but for whatever reason, we just weren't able to see that. And so, at any rate, that's kind of where things stand. And in this process, kind of trying to make sense out of the results early on, like why was I wrong in essence? um, I started to figure out, well, it all kind of boils down to like mathematics and statistics and
Right.
prevalence rates and things like that. And looking then again outside of behavioral health, what can we learn from other disciplines? And there's actually very similar issues in oncology, cancer treatment in particular, where there's this long history of cancer screening tools being wrong, highly sensitive, and having lots of false positives and leading to unnecessary treatments that actually increase potential consequences and harms because of the treatments have side effects, things like that. And so in the cancer field, they've learned their lesson, which is why we now have recommendations of instead of screening everybody for colon cancer, we only screen men
Hmm.
above a certain age. And instead of doing mammograms for all women of all ages, we only start doing it routinely for, once women get to a certain age or if they have these other risk factors, because the costs outweigh the benefits if we do it everywhere. And so trying to inject those ideas into the dialogue as it relates to suicide risk screening has been really challenging. It's been really difficult, I think, for the field to acknowledge that there might be consequences associated with this activity that we otherwise really want to believe is life saving.
Well, and I don't know, you're probably familiar with the paper that came out. There's a meta-analysis that came out. No, it was a systematic review that came out not too long. Well, not too long ago. I'm getting old. A handful of years ago, sort of talking about the potential iatrogenic effects of hospitalization for suicide.
Yes.
And like that paper, reading that really, it was really influenced me a lot. When you talked about the cancer example, that triggered that because it's like the like hospitalization, while there's not good evidence or maybe any evidence that it's helpful for suicidal folks, there's some evidence that it's hurtful for them. And
Yeah.
I don't want to overstate that. I'm sure that there are many cases where it's not, whatever, right? But the point is, this is not an innocuous intervention. And I mean, even if you just think about, we're going to pluck this person out of their life, even if it's just for a few days, even if just for a few days, which oftentimes is longer, but that imagine for any of us plucking us out of our lives for 3 days, that has consequences, and
Yeah.
there is, so, to do that, it's not just, it's not just, well, it might be a false positive, but that's okay. Because no, we could be taking people who it is a false positive and actually hurting them. This is not just an innocuous intervention. There's
Yeah.
a cost to it.
Yeah. And there's, you know, so you're absolutely right. And when we think of, so now I'll play devil's advocate because I'll play
Mm-hmm.
what the opponents will say. Well, I mean, obviously, if someone screens positive for suicide risk, I mean, we're not going to just hospitalize everyone. That would be a terrible idea. And so you should do a risk assessment. I mean, the whole point of screening is to figure out who needs further assessment so that we can give them the right treatment. And hospitalization is going to be rare. It's going to be more likely medication therapy, something like that. And so I say, okay, well, basically what we found in our study, that depression PHQ-9 study that you mentioned, was that in essence what was happening was a suicidal ideation screening. It was identifying fewer patients, and it was in essence sort of shifting the focus away from the pool of people who were actually attempting suicide, and now kind of shining the spotlight on people who were not going to attempt suicide. And so it's like, all right, if the purpose of screening is to identify the people who need further attention, then the suicidal ideation screening is actually working against that purpose. The depression screening is better suited for that purpose. Um, and on top of that, well, let's talk about some of these other interventions that are more probable. So things like, antidepressant medications, things like that. Well, medications have side effects.
Right.
Um, you
Right.
they can, for some people, not everyone, but
Mm-hmm.
it's something
Mm-hmm.
like around 20 to 25% of people when they start an antidepressant will experience one or more side effects, sleep problems, sexual dysfunction, fatigue, energy changes, things like that. I was like, so now, in essence, when you do universal screening in low risk settings like primary care, schools, things like that, you are now exposing
Mm.
25% of the positive screens to side effects. So those are the potential harms associated with it. But because the population as a whole, the risk of suicide is low, the potential for benefit is actually shrunk because there aren't as many people who could possibly benefit as a result. So now you've tipped the scales away from overall benefit towards possibly overall harm. And here, harm meaning not necessarily this causing suicide, but these other
Mm-hmm. Mm-hmm.
side
Mm-hmm.
effects and
Yeah.
things like that. And so, it's well understood in other health disciplines, other areas, but we've not imported those lessons yet into suicide prevention, which is frustrating. And so I've sort of gotten a little more assertive with the
Mm-hmm.
issue, where I've even started asking questions of like, well, how many kids are we willing to harm in order to prevent
Mm-hmm.
suicide? Um, and if we are, and we now have multiple published randomized controlled trials of universal prevention programs in schools that are consistently finding increased depression and anxiety amongst kids. And the thinking is that we have an otherwise healthy pool of people, and our treatments and interventions that are really great for those clinical cases are perhaps not so great in a healthy population. And to further reinforce the point is the way to understand this is that we have really good treatments for cancer, things like chemotherapy, If you have stage 3, stage 4 cancer, chemotherapy could possibly save your life. Um, but that doesn't mean we should give everybody chemotherapy to prevent them from getting cancer. That's a terrible idea. And I think there's similar lessons to be learned when it comes to behavioral interventions, psychosocial interventions, psychiatric medications. And I think we just have a default setting of there are no risks associated with therapy or with skills training, things like that. But perhaps there are.
Mhm.
And perhaps we should be willing to at least consider that.
So we've what are some for folks who want to learn more about what we're talking about now or in general, what are some resources of yours or others that you tend to point people towards that I can include in the show notes?
Yeah, I would say, I published a book a few years ago where I talked about a lot of these issues. The name of the book is Rethinking Suicide. And I've since been thinking a lot more about it, and so the ideas that I present in the book, we kind of deep dive much more so than what we, obviously had time to do so today. And there are a lot of sort of outgrowths of that work that are more in like the published academic literature, and so I could certainly provide some kind of key citations or key studies that I think people might be interested in.
Yeah, and if I mean, whatever you want, I would be happy to take and include. If I link to your website, is there? Because I'm thinking that probably one of the things that folks who listen will want to be able to get is sort of the crisis response planning stuff. Is
Mhm.
there a link to that on your website?
Yeah, there's so I maintain a website. It's suicidepreventiontherapy.com, and that has information about BCBT for suicide prevention, crisis response planning, lethal means counseling. It's the portal that we have, for trainings. People are always asking, how do I learn more? How can I learn how to do this? And there's information on there for, if you're in an agency and you want to train other clinicians, you can contract with us. But there's also links to other third parties that have like pre-recorded different talks and different trainings that we've done that people can watch.
Oh, that's wonderful. I will link to that. Thanks so much for watching. If you found this video helpful, please like the video and subscribe to the channel. And I'll see you in the next video where we continue exploring the science of psychotherapy and applied psychology.